Hello, I am Richard Underwood and I'm a non-invasive cardiologist and cardiac imager working at the Royal Brompton and Harefield Hospitals in London, UK. It's a pleasure to be speaking with you today, although remotely, but I'm sure we all know the reason for that. I hope that we'll be able to meet personally in due course. So the topic of my presentation is cardiac imaging in stable coronary artery disease, the broader perspective, by which I mean we hope to look at not just my own imaging technique, which is radionuclide imaging, but also compare it with the other non-invasive imaging techniques available. So what is needed in patients presenting with chest pain, stable chest pain, and known or suspected coronary artery disease? Well, it always starts with clinical assessment, both history taking and examination, and that might include treadmill exercise testing, where we're looking at symptoms and exercise times on the treadmill, either combined with the ECG or with some form of non-invasive imaging. We need to know about left ventricular and valve function, coronary function, coronary anatomy, and ultimately we need to discuss the patient in a multidisciplinary team consisting of cardiologists, interventional cardiologists, surgeons, and cardiac imagers to decide whether intervention might be helpful for the patient, and if so, what form. So you can see that all of this involves a lot of different imaging techniques, and almost by definition, this situation is a multimodality imaging. Well, if we look at the different imaging techniques performed in Europe, this is a slightly old survey, 10 years old now, but it looks at the number of tests per million population per year, used by myocardial perfusion scintigraphy, by PET perfusion imaging, by stress echo, magnetic resonance imaging for perfusion, and by coronary CT. And I should add that the bars indicate the lower and the upper end of the estimate from the survey. So there's quite a broad spread here. But nonetheless, radionuclide imaging is the most common, followed by coronary CT. And I think in the 10 years since, CT angiography has increased significantly. In fact, if we look at more recent data from the UK, now coming up to about 5 years ago, this is the treadmill test, which is slowly declining. This is radionuclide imaging, which rose and now is stable. And we can see that this is CT coronary angiography with a rapid growth in the last 5 or 6 years, and slower rates of growth for stress echo and for perfusion MRI. Now let's look then at these different techniques for just a thumbnail sketch. This would be the echocardiographer's view of inducible perfusion abnormality, Dobutamine echocardiography. So you can see that there's an obvious apical aneurysm here, but let's concentrate on the lateral wall, where you can see at rest it is not contracting. With low doses of dobutamine, it improves in the contraction, and then with higher doses of dobutamine, it stops contracting again. So this is the biphasic response, telling us that there is viable muscle that is akinetic at rest and which has inducible ischemia, hence hibernating myocardium. But we will come back to hibernation in a moment. This is the radionuclide way of looking at things, and if you're not familiar with the technique, it involves injecting a perfusion tracer during stress and then at rest, and acquiring images. So these images in tomograms are three-dimensional images of the perfusion and viability throughout the myocardium. I prefer to look at these images in the polar plot format, where the apex is in the center, the anterior wall, the septum, the inferior wall, and the lateral wall. So the resting polar plot here tells you about myocardial viability. Wherever there is a myocyte that's alive, it will take up the tracer, and we can see that there is a clear defect here of a previous infarction in the anterolateral region. And you can see that during stress, this defect is rather larger and deeper, and there's also a remote inducible perfusion abnormality here in the infralateral territory. In addition, of course, we're looking at ECG gated images to tell us ejection fraction and volumes and so on. Now, that would be SPECT, which is widely available, but is this the future of radionuclide imaging? This would be PET. For instance, there are now low-cost cardiac PET cameras available, and coming shortly, we hope, fluorine-labeled perfusion tracers such as fluoperidase. It's not available yet, but will this be the future of radionuclide imaging? Well, one of the advantages of PET is that it is possible to quantify perfusion. So here we have, in the same format as I showed you with SPECT, the rubidium PET, stress perfusion and rest perfusion, and there's an obvious inducible perfusion abnormality in the left anterior descending and probably the right coronary territories as well. But because of the sensitivity of the camera, we can acquire images every 6 seconds as the tracer passes through the blood pool and into the myocardium. And we can use what's shown here, a 2-compartment model, to measure perfusion in quantitative terms, mils per gram per minute, at each point within the myocardium. You may not be able to read the numbers here, but these are stress perfusion in mils per gram per minute, rest perfusion in mils per gram per minute, and then stress divided by rest, which is the myocardial perfusion reserve. So, for instance, in this patient, we're seeing that stress perfusion at the apex and in the septum is significantly reduced. Normal would be above 2 mils per gram per minute. And similarly, myocardial perfusion reserve is reduced. Again, this normal would be greater than 2. So this is a big advantage of PET. But things are developing in SPECT as well, and we now have solid-state cameras which have something like 5 times the resolution and, 5 times the sensitivity and 2 times the resolution for detecting the tracer. Here are a couple of commercially available cameras from Spectrum Dynamics and from GE. And if I were to show you these 3 different patients and tell you that one of them was acquired using thallium with a solid-state camera, another was acquired using technetium perfusion tracer with a solid-state camera, and the third was acquired using rubidium PET, and I asked you which was which, I think you might guess it's like this, by virtue of lower resolution, better resolution, and the best resolution. But actually, it is like this. So you can see that with a solid-state camera, particularly with technetium, the resolution is at least equal to PET, probably better than PET with rubidium, as opposed to PET with tracers such as ammonia. So this has been a big advance in myocardial perfusion scintigraphy. And the other thing we can do with dynamic SPECT is we can quantify as well, just as we do with PET. So here's a patient with 3-vessel coronary disease, as you can see. With the stress and rest polar plots, I think you'd say that there's an inducible perfusion abnormality in the inferior wall, in the anterior wall as well. But when we look at the stress perfusion, you can see that it is low, it's abnormal in all 3 coronary territories, and the perfusion reserve similarly is very low. So this would be a typical example of, if you like, balanced ischemia or 3-vessel coronary disease, where looking at quantitative imaging alone, we underestimate the amount of ischemia. But we can now overcome that with quantitative SPECT. Turning to magnetic resonance imaging, well, there is a great deal that can be done with MRI, from anatomy, function, flow, fibrosis, looking at coronaries. And here we're going to concentrate on perfusion MRI, and perhaps think a little bit about some differences with perfusion SPECT. Well, I hope you won't think me too biased by having loaded the dice with more disadvantages for MRI than advantages. But to be fair, let me highlight what I think are the most important points here. First of all, MRI perfusion works. Certainly in good hands, it can give you estimates of qualitative and even quantitative perfusion now. But some of the disadvantages are that it is gadolinium is a mixed blood pool and tissue contrast agent. And this really is not an ideal contrast agent to use when you're trying to quantify myocardial perfusion. The ideal would be either a blood pool agent, a pure blood pool agent, or better still, a microsphere agent such as we have in nuclear cardiology. There is limited myocardial coverage. Usually we're just acquiring 3 short axis slices. So in contrast to the 3-dimensional imaging of nuclear cardiology, this is a potential limitation. And certainly there are limitations when you're trying to assess inducible ischemia superimposed upon partial thickness scarring. We can overcome with modern MR techniques some of these things. So this is now a study that we presented some time ago using 3-dimensional magnetic resonance perfusion imaging. So you can see now the short axis slices all the way from the base to the apex. And you can just make out, I think, that in the septum and the anterior wall, there is a reduced delivery of tracer or delayed delivery of tracer to the myocardium, which is giving us exactly the same information as here in the polar plots from SPECT. But to be honest, this is not the technique that is most commonly used still in magnetic resonance centers. Turning to CT, well, I know that Jerome Bax will be speaking in more detail about CT, so I won't say too much about it. But clearly it's very attractive in showing us the lumen of the coronary arteries, but not only the lumen, also the wall of the coronary arteries and calcification within the arteries. So we can not only see anatomical disease, but also make an estimate of the percent stenosis and hence an estimate of coronary function. But if you want to know function, if you want to know, for instance, whether this atheroma is impeding perfusion or flow, then I would say you should use a functional test. Now, I'm sure that Jerome Bax will mention that there is nowadays CT-FFR, so it is possible using hemodynamic equations to go from the coronary anatomy to estimates, computed estimates of coronary pressure downstream of a stenosis. So here we're looking at the coronary fractional flow reserve measured by CT, high in the proximal left main, and then decreasing distal to a stenosis to give us FFR equivalent of 0.7 in this particular patient. But our own experience is that this is a good technique when there is very little disease, certainly no calcified disease, but it's rather less reliable when there is calcification, making it more difficult to know the precise anatomy of the coronaries. So here's a patient, for instance, with dense calcification in the LAD, but not obstructing the LAD at all anatomically, and here the perfusion image shows no inducible perfusion abnormality. So I think this illustrates one of the limitations of CT-FFR at the moment. In my opinion, a very good combination, though, is CT coronary angiography with, let us say, radionuclide perfusion imaging. So here are some examples of a patient with both LAD and right coronary disease. You can see that there's an inducible perfusion abnormality in the inferior wall and in the anteroseptal region and apex. But nicely you can see exactly where the coronary arteries are running with this overlay, and you can see exactly which coronary artery is responsible. For instance, here at the apex, you can see the second large diagonal branch, which is the cause of that ischemia, as opposed to the main LAD. And our own study, the Vinci, would say that 25% of coronary territories were reclassified by combining a knowledge of anatomy and of function. So let us talk now a little bit about the relative diagnostic accuracy of the different techniques. Well, this is a slide, to be honest, that I absolutely hate. And I say that because the concept of sensitivity and specificity is really very artificial, particularly when it is sensitivity and specificity for detecting an anatomically significant stenosis detected by, for instance, invasive coronary angiography. But for better or for worse, these are the current ESC guidelines with a meta-analysis of the sensitivities and specificities of the various different imaging techniques. And perhaps with the exception of the exercise ECG, I think it's fair to say that all of the different imaging techniques have roughly equivalent sensitivities and specificity, if you like. We can pick bones in some of them. Vasodilator stress MRI seems to be here rather less sensitive and less specific, but let's not speak in too much detail there. Here is in contrast to that meta-analysis, here is our Vinci study, European study, where patients presenting with chest pain and an intermediate likelihood of coronary disease were studied either by SPECT or PET, but in addition, in the same patients, by stress echocardiography and stress MRI, and also by CT coronary angiography. And the comparison was with invasive coronary angiography with FFR. And you can see here that these are just the patients with good quality images as opposed to the whole set of patients. But you can see that when there are good quality images, the sensitivity and specificity of SPECT is pretty much the same as that of PET. And here we're looking at very surprisingly low sensitivity for stress echo and for perfusion MRI. This is partly the result of Italian studies commonly using vasodilator stress for echocardiography, as opposed to, for instance, dobutamine or exercise stress. But the point I want to make about this is the equivalence of SPECT and PET when images are of good quality. But here is another reason why I don't really like the concept of sensitivity and specificity as a binary thing. It's either positive or negative, because here's an example that I showed you before. If this patient does not have disease in the, let's say, the intermediate artery and the circumflex artery, then I would really be very surprised. So if all of your patients look like this, then your sensitivity and specificity are going to be really very high. In contrast, if all of your patients look like this, then you may, in terms of sensitivity and specificity, do less well. For instance, is this inferior attenuation artifact, or is it normal? Well, you might jump on one side of the fence and come down in your report and say it's abnormal, and then you will get the letter saying, I'm pleased to tell you that the coronary angiogram was entirely normal. But actually, reports are not black and white. You can say in your report, I'm not sure whether this inferior wall is normal or abnormal, but if it is abnormal, it's certainly not profound ischemia, unlikely to be prognostically important, and therefore you might be able to hold off with coronary angiography depending upon how the patient's symptoms respond to medical therapy. So I think this is the more intelligent use of our imaging techniques compared with forcing them to be a binary normal or abnormal. So speaking of the intelligent use of techniques, we can go to some of the guidelines. Here we have the current ESC guidelines for the diagnosis and management of chronic coronary syndromes. And this would be the algorithm in the setting of patients presenting with stable chest pain. As we've said, always assess symptoms and perform clinical investigations, consider comorbidities, quality of life, resting ECG, etc. So from this you can assess the pretest probability or clinical likelihood of coronary disease. And here you will have a spectrum of clinical likelihood of obstructive coronary disease causing the symptoms. And the suggestion is that down here you need do no tests. In the lower end of the range, then an anatomical test such as CT is really very good because, as we've said, CT is particularly good at ruling out obstructive coronary atheroma. In the higher intermediate range, then testing for ischemia, preferably by imaging, would be the thing to do. And if there's very, very high likelihood, then you might actually go directly to invasive angiography in order and combine that with FFR in order to perhaps take a decision on the table about intervention. So there we have some guidelines. Now, that's more or less to do with diagnosis. Let us speak a little bit about prognosis. And the studies go way back many years now, 20, even 30 years, in many different patient populations that I've listed here, looking at the annual hard event rate, depending upon whether, in this case, myocardial perfusion scintigraphy is normal or abnormal, with usually quoted an event rate less than 1% per year for a normal myocardial perfusion scan, and increasing event rates for increasing abnormalities of myocardial perfusion scan. So ischemia imaging does have prognostic value. One can be a little bit more, shall I say, semi-quantitative about it. So for instance, here we have a patient with a transmural scar at the apex, an inducible perfusion abnormality, not very large, but at present in the inferior wall. And we can assign scores to the 17 segments and add these up, and we can come to a summed rest score as a percentage of maximum. So this tells us, in this case, that 12% of the myocardium is scarred. And a sum difference score, that's the difference between this and this, which tells us about the ischemic burden. And we can assess that ischemic burden semi-quantitatively and correlate that with either with event rates per year from the literature, going from very low to very high, or we can use these terms, just low, moderate, and high, etc. So now this would be our routine in diagnostic patients, where we not only make a diagnosis of underlying coronary obstruction, but also an assessment of the likelihood of future coronary events. It is interesting that not only can one predict the likelihood of events, but also what those events might be. So here are some data from Cedars-Sinai. The global chi-squared is just the predictive power, in this case for myocardial infarction. So we can see that the sum difference score, or the ischemic burden, is actually the most powerful predictor of an ischemic event such as myocardial infarction, with ejection fraction being relatively low down in terms of prognostic power, compared with predicting cardiac death, for instance, by heart failure or arrhythmia, where ejection fraction now is the most powerful predictor, with ischemic burden being lower down the ladder. So I think that's quite an interesting study, telling us where we should focus our management, either on the ischemia or on let's say the heart failure or left ventricular function. And here we are. This is a widely quoted study now, actually a very much more recent update to Cedars-Sinai data in nearly 20,000 patients who were followed up over nearly 5 years. And these are contemporary patients imaged by solid-state nuclear cameras, looking at the ischemic perfusion defect, that is the ischemic burden, against the hazard ratio for early revascularization versus optical medical therapy. So you can see that where there's very little ischemia, then the hazard ratio of revascularization is positive. In other words, it can be harmful. But with increasing ischemic burden, you can see that then revascularization becomes the better outcome. And the crossover is usually said to be around 10% of ischemic burden. And the radionuclide technique is really the only technique of the non-invasive techniques, or any technique, that can easily measure this ischemic burden. And so this is very powerful data to support using ischemic burden in triage of patients between medical therapy or intervention. Let me speak very briefly about heart failure. So I'm going a little bit off stable coronary disease now. So let's talk about what we want to know when we are imaging the failing heart. Well, here are our various techniques. Here are some of the things we might want to know. And I've shown here with the solid lines the information that you can obtain. So for instance, by MRI, we can look at fibrosis, left ventricular function and perfusion, etc. Just in case I annoy you by not showing your preferred line, there are other lines here which I've made as dotted to suggest that this is information that is perhaps not so well validated or not so commonly used, but it is possible in certain settings. But what I've actually done here is there's only a single line going from nuclear to viability. Now, why would that be? You will say that MRI can assess viability, can't it? Well, actually, officially, no. MRI is assessing by late gadolinium enhancement. It's assessing fibrosis rather than viability, as opposed to the nuclear technique where you need a viable, meaning a living myocyte, to take up the tracer. So this is one of the big advantages of nuclear imaging when it comes to viability. The disadvantage compared, for instance, with MRI is resolution. So let's talk a little bit more about viability and hibernation. Now, sometimes these terms are used interchangeably, but I think that is confusing. I do not use them like that. I use the term viable to mean simply muscle that is alive, no more than that, no more and no less. Hibernating myocardium, as defined by Rahimtullah actually many years ago, is myocardium that's alive. It has reduced function at rest, usually in the setting of chronic coronary artery disease, but it has the potential to recover in function after revascularization. Stunning might be similar. It's alive, also has reduced resting function now in the setting usually after an acute ischemic event, but that recovers spontaneously without the need to intervene. So usually in clinical terms that is rather less relevant. And if you take home one slide from this presentation, please let it be this, because hibernating myocardium you should think of as muscle that is alive, that is not contracting at rest, but that is susceptible to ischemia, because hibernation is an ischemic syndrome. So let me just show you an example. This is hibernating myocardium assessed by the radionuclide technique. So we can see here from the stress and the rest polar plots that there is a transmural defect at the apex, but there's also an inducible perfusion abnormality, not very extensive, but definitely present in the anterior wall. So if we look at the rest vertical long axis image here, you can see that and we look at the distal anterior wall, there's quite a lot of activity here. So the muscle is viable. With stress, there is less activity, so there is an inducible perfusion abnormality there, or it is ischemic. And then in terms of motion, what is it doing? Well, the answer is, of course, as you can see, it is doing really nothing. So this fulfills that triad of signs for hibernating myocardium. And this is a patient where this resting ejection fraction is 19%, and it actually recovered to 32% after full revascularization. So coming close to the end now, another little topic I'd just like to speak about, health economics. I'm not going to go into the health economics jargon, but many of the studies available in this area are of cost effectiveness or cost utility, where utility refers to quality adjusted life years. How much money do you have to spend in order to buy for a patient one quality adjusted life year? Well, I can't resist showing this study really because it has over 250,000 patients aged over than 66 from Medicare data in the USA. And these were patients presenting for diagnostic testing of coronary artery disease. And it's observational and retrospective, so it's not prospective. But some patients had an initial myocardial perfusion scan. Some patients had an initial CT coronary angiogram. And this is the adjusted odds ratio of having coronary angiography if they had the anatomical test first compared with the functional test first. You can see that they were twice as likely to have angiography if they had the CT scan first. They were 2.5 times more likely to have intervention by PCI. They were 3 times more likely to have intervention or revascularization by coronary bypass grafting. But did this do the patients any good? Well, to be fair, yes. There was a reduced incidence of non-fatal myocardial infarction in the patients who had the anatomical test first. But the mortality was exactly the same in both sets of patients, and the cost was significantly higher. So this is just a caution that initial anatomical imaging may well drive you, or may well drive the oculostenotic reflex and increase overall costs of management without necessarily improving mortality. There is actually only a single prospective controlled trial of the various different imaging techniques for cost effectiveness in this setting. This is the CECat trial performed in Cambridge in the UK, and these were 900 odd patients with stable chest pain, no known prior coronary disease, and an abnormal stress ECG. So they were randomized to go straight to coronary angiography, nuclear perfusion imaging, perfusion MRI, or stress echo. The details here of the numbers don't matter too much. But looking at cost effectiveness, this is actually shown as the probability of the various tests being, as an initial test, being cost effective compared with the initial test being invasive coronary angiography. And it's shown here on a scale of willingness to pay threshold. So in the UK, our body called the National Institute of Health and Care Excellence, or NICE, tends to support techniques that will buy a quality adjusted life year for the patient between costing £20,000 to £30,000. Call it 25 to 35,000 US dollars. So this would be the willingness to pay window, and you can see that in that window, nuclear imaging is about 80% likely to be cost effective compared with invasive angiography, stress echo about 50%, and perfusion MRI is actually unlikely to be cost effective. So I'll just repeat that this was a prospective randomized cost effectiveness study. So it is fairly solid data to support the use of radionuclide perfusion imaging in this setting. Now, as a last topic, I can't resist this temptation. It's no longer to do with ischemic heart disease, but nuclear cardiology nowadays is very much more than just ischemic heart disease. We are a national referral centre for sarcoidosis. I'm not sure how common this is in Brunei, but this, for instance, is a patient with isolated cardiac sarcoidosis imaged by FDG PET. So FDG is an inflammation marker. we suppress normal glucose metabolism in the myocardium with a low carbohydrate diet and fasting. And so when there is uptake within the myocardium, you know that that is inflammation, and this is intense activity in a patient with isolated cardiac sarcoidosis. So it is very good for diagnosis and now is incorporated in the diagnostic criteria for cardiac sarcoidosis. Equally importantly, it can be helpful in the monitoring of treatment. So this is a patient now with widespread myocardial and thoracic nodal activity, here mainly in the right ventricle actually. Before treatment and 6 months after treatment, you can see that the thoracic activity has been entirely suppressed. By the way, these are rubidium perfusion images to look at viability. So we do see a little bit of scarring in the basal inferior wall and the basal septum, which obviously that scarring does not improve with treatment, but the inflammation does improve. Comparing nuclear with MRI in this setting, it's very clear that the nuclear technique is more sensitive than MRI for inflammation, but MRI, because of its resolution, is more sensitive than the nuclear technique for myocardial scarring. So normally we would be comparing both of these techniques. Device infection as well, device infection and infective endocarditis, increasingly common, sadly. And here is a patient. This now is normal myocardial uptake because we actually have not suppressed normal myocardium, but there is intense activity around the pacemaker. And then what is happening? What's happening over here? If I go to the sagittal image, you can see that what's happened is the infection has actually tracked down the leads into the right ventricle and is now pointing out and coming out as a sinus, actually on the anterior chest wall. So quite how this patient is still alive with such a sinus, I'm not very sure. But obviously most of our patients are not so severe. But nuclear imaging is now, alongside white blood cell nuclear imaging, FDG is now a very common technique to use in these patients. Aortitis, giant cell arteritis, Takayasu's disease. Well, obviously you're going to be looking at thickening of the aortic wall by CT, but this is quite subtle, and I have to tell you with FDG PET there's really nothing very subtle at all about the inflammation here. So in these patients, nuclear cardiology has an increasing role. Then what do you think this is? What is the tracer? What is the diagnosis? Well, the tracer is DPD, which is a bone-seeking tracer. You can see that from the activity within the bone here. But normally this tracer does not go to the myocardium, and you can see that it has. And this is a sign, this is a very specific sign of myocardial amyloidosis, specifically the transthyretin variant as opposed to the light chain variant, AL amyloidosis. So increasingly common technique now that we have drugs that are effective in treating amyloidosis. So we're coming up to 40 minutes now. Let me just conclude. There is no one-stop shop in managing patients with coronary artery disease. If we look at the different imaging techniques, CT coronary angiography is very effective in ruling out coronary disease, possibly less helpful when coronary disease is present. Stress echo can be effective in good hands, but it is insensitive in some clinical settings for inducible ischemia. Myocardial perfusion scintigraphy is both effective and cost-effective, with proven benefit for clinical outcome. And perfusion CMR can also be effective in good hands, but its real-world effectiveness is perhaps less certain, and it may not be cost-effective. So successful cardiac images will not have all of their eggs in one basket. And let me just say that you therefore need to have all of the imaging techniques available to you. If that is not the case, for instance, for nuclear cardiology in Brunei, then I would be delighted to speak in more detail with you and to see how it is possible to implement high-quality nuclear cardiology in your setting. I'd be delighted to collaborate. Thank you very much for your attention, and goodbye.